Hi everyone. I'm back with the diabetes series. This is part 3, and it's going to be about diabetes complications. If you're looking for medications or an overview, it's in another video, but this lecture is just for complications. So let's rewind a little bit and let's refresh that I had mentioned that diabetes causes a lot of issues across the body in different organs. And it's sort of a multi-system chronic disease. It damages the vessels, and therefore, you're going to see that you're going to have issues or diseases that are going to start developing if your glucose is not under control. Diseases such as stroke, a heart attack, problems with your visions, problems with your kidneys, with a wound healing, with the nerves, etc. We're going to talk about a few of those issues or complications of diabetes. Now, keep in mind, they're not all of them, but we're going to talk just about a few of them. So, some of the acute complications are hypoglycemia and hyperglycemia, which then can lead to diabetic ketoacidosis or DKA, or hyperosmolar hyperglycemic syndrome, HHS. Now, some of the chronic complications, such as the picture that I have here, um, they affect the vessels and the nerves. So you're going to have retinopathy, which can lead to blindness, nephropathy, which can lead to end-stage renal failure, neuropathy, which can lead to, amputations and wounds and etc. And then this cardiovascular disease umbrella that falls, and you'll have stroke and heart attacks, as well as peripheral artery disease. So let's start with first going out about hypoglycemia. So hypoglycemia is kind of defined of a glucose level that less than 70. Now, I wanted to make a bracket here and just sort of tell you that some individuals, some clients could experience hypoglycemic symptoms and not necessarily be below 70. Let me give you two examples. You might have someone that is a chronic diabetic, brittle diabetic, that is always in the high 200s, and suddenly they drop to 120. Is still not considered as the definition of hypoglycemia, but because they're normally at a high glucose level, you drop them to a sort of normal level, but still lower than what they're normally at, they can experience hypoglycemic symptoms. Versus then you also could have somebody at 50 glucose level or 40, and you think, oh wow, they're possibly going to be showing the symptoms, and they're going to be talking to you like nothing. So you can have those two cases. So I always say, yes, the definition is less than 70, but just know to listen to your patients. Listen carefully to them. They know their body better than you. So if they tell you, hey, I think I have a hypoglycemic event, even though they're saying, or you might take their glucose level and it might be 100, listen to them and basically pay attention. Some of the causes that can lead to hypoglycemia are, alcohol, too much insulin, maybe not eating enough, or a sudden change of hypoglycemic agents. It could be maybe too much insulin for some reason, okay? Just to mention a few. Some of the symptoms that the client can experience is sweatiness, weakness, a lot of tremors. They start shaking, irritability. They could feel hungry. They could be dizzy, tachycardia. Okay. some confusion. As the glucose starts dropping and your brain starts lacking glucose, you're going to have this visual and speech disturbances, like they can't speak or they might see black spots in their vision. You could also have tingling of their hands and feet, all the way to losing consciousness and death, honestly. Okay. Um, the next one would be how to treat hypoglycemia. So we treat hypoglycemia depending on the situation. So, for example, at the hospital, you're going to have patients with IVs and you're going to be routinely going into their room, perhaps, hourly rounds. So you might be able to recognize this symptom right away and treat it with maybe, if it's really low, with IV dextro. However, we also want to teach our clients, what about if you are on the field or you're at home that you might not have IV dextro to push, right? Or IM glucagon. So let's talk about the difference between somebody being awake versus somebody being sort of unconscious. So if someone's awake, we kind of want to go with the 15 carbohydrate rule. It's called the rule of 15, where we tell our patients to eat 15 grams of simple carbohydrates. And simple carbohydrates are something like a soda or a candy, hard candy, or a tablespoon of syrup or honey. Orange juice is commonly given in the hospital. Something easy that the body does not have to break down and can be absorbed very quickly. Once you do that, you wait 15 minutes and then you repeat your glucose level. If it's still below the 70 mark or you're experiencing symptoms, you repeat it 2 to 3 times more, the same pattern. Once the client sort of stabilizes and their glucose starts rising, then you want to switch from a simple carb to a complex carbohydrate. And this could be like peanut butter, crackers, or sandwich. And it's just to sort of prevent a hypoglycemic event again. Now, let's say this is, something you can teach for at home. Let's say you're at the hospital. Well, we have hospital protocols that kind of tell us, okay, well, if the sugar is less than this, push or give something orally, do it times two, and then call the doctor. So you kind of want to follow your hospital policy or protocol, but typically you do give the 15 grams one, twice, and if it's still, not working, then you want to contact the doctor, or if you have Dextro IV on hand, you want to push it. Now, just so you'll know, every crash cart has Dextro IV. So even if you might not have it at hand or you might not have an order for it, your crash cart will have it. Okay, now if we are unconscious, then that's a different story because we may not be able to tell the individual, hey, swallow this, orange juice or drink this for us. So in that instant, we do always want to proceed with IV dextro, IV glucose, or IM glucagon. At home, what we can do is for sure call 911 immediately. And then you could basically put in their mucosa, in their mouth, like syrup or honey, kind of like by their cheeks or in their mucosas by the lip, cake frosting or anything sugary that the the membranes can absorb and can bring hopefully your patient, your family member back. So we always want to educate the family in regards to this, not just the client. The family kind of needs to know what to do in the event because whenever they have lost consciousness or they're in a very hypoglycemic event, sometimes they cannot see and they cannot process information in their brain. The brain doesn't have the sugar to really think, oh my God, what do I need to do? So we involve the family. All right, then we're going to move to hyperglycemia, and that's defined as more than 200 blood sugar. This could be because maybe you're not taking your insulin or your hypoglycemic agents, or you are going through a illness, sickness, infection. It could be also because of stress. Um, Stress causes a lot of cortisol in your body, and cortisol is straight sugar for the body. So, because of that, when we are under a lot of stress, our glucose levels increase. The symptoms are all your P's, lots of urine, lots of thirst, and lots of hunger, blurry vision, dry skin. Um, and if they develop to DKA, you might have some nausea and abdominal pain. What we want to do is hydrate them, hydrate, and increase or start giving your insulin or your oral agents. Contact medical help um, immediately. If you have a way of testing for ketones, then you do that. Excuse me. And then increase your glucose monitoring, checking that glucose level often. So you'll know if your insulin or your oral agents are working. You want to make sure that you're being hydrated because when we have our glucose elevated in our blood, in our bloodstream, the body is going to try to eliminate it. So you start peeing it out. That's why polyuria happens. And in the process of excreting all these glucose molecules, you're losing a lot of fluid as well. So you can become very dehydrated, which can lead to that HHS. Um, and so increasing your fluid intake is very important, as well as monitoring those INOs. This is just a little easy to read. You can pause the video if you need to read it and take a picture. Same with this one. All right, so then let's talk about DKA, diabetic ketoacidosis. And DKA is one of the causes for a acid-base imbalance called metabolic acidosis. Um, and that's in another lecture, but just so you'll know. So what happens with DKA? Well, it's considered a medical urgency. Usually it happens in type 1 diabetics, but can be seen in type 2. This is when you have complete deficiency of insulin, like literally your glucose levels go extremely high. Your diabetes out of control. That's why it almost happens mainly in type 1. Um, Typically, you're going to see people that maybe they have ran out of medication, they're underdiagnosed, they haven't been diagnosed yet, or they're newly diagnosed and they're still trying to find a balance with their insulin and glucose and all of that. The onset is typically gradual or sudden, depending on what's causing it. Um, and it could be between, days to weeks of the patient being deprived of that, sort of insulin and having high glucose levels. Some of the precipitating factors are stress, infections, not having your medication, and not being diagnosed properly. So let's go a little bit of the path, though. I try to make it very simple here because the book really goes into like a lot of explanation about this, but I just want you to understand the basics of it. So we have a decrease or very little insulin. Then your body starts breaking down fats in order to give energy and basically give glucose molecules to these cells that are starving. The breakdown of the fat cells produces this ketone bodies, which are very acidic, and then they lower the pH, which then turns into a metabolic acidosis state. In the same time, your body's trying to excrete all this glucose molecules, dehydration happens, and then you have all these molecules flowing around, which then gives you the results of the high glucose. When the body is in metabolic acidosis state, um, your lungs compensate by taking rapid, deep breaths, and those are called Kussmaul breaths. And it's basically removing the carbon dioxide that is very acidic as well in order to sort of try to balance and fix your pH. So you're going to have this Kussmaul breathing as well when we are on DKA. So let's look at the signs and symptoms. Usually the first sign is that the person feels tired and they just feel like something is wrong. I'm tired, I'm weak. They start urinating more often. They start having lots of thirst and hungry. Maybe their mucosa start getting dry, their lips. You could have tachycardia and orthostatic hypertension. And then from the acidic state, when your pH starts lowering, that causes nausea and vomiting as well as abdominal pain. Most of the clients have this fruity, sweet breath to them. If you if you are next to someone on full-blown DKA and they talk very close to you or they blow some air at you, you're gonna feel like you're gonna smell like their breath is like kind of fruity, fruity sweet. You're going to have this small breads. And then, as far as electrolytes, you could have this electrolyte imbalance with the potassium being high. And they could also experience this confusion and drunk like state, like they're drunk and slurring their speech and whatnot. So here are the labs. You're going to have a glucose high, more than 250. You're going to have ketones that are positive, and then your low pH and your low bicarb. So what do we do to treat it? So the first thing that we need to do to treat it is lower the glucose, honestly. But that's in a nutshell. But, before clients were usually all hospitalized. Now, with technology and these continuous glucose monitors and, you know, patients that are able to have glucometers at home, you can recognize it pretty early and sort of start treating it at home, preventing the patient from, kind of being hospitalized. Now, yes, we still hospitalize patients with DKA, but it's usually whenever there's, severe dehydration or they need IV insulin or they need some kind of electrolyte replacement that they cannot do it at home. So you want to monitor their consciousness. You want to protect the airways. So always think about airway first, like ABCs, okay? You want to hydrate them and give them IV insulin right away to lower this glucose level. If we control their glucose level, their dehydration will, sustain and you start fixing everything else. The glucose monitoring, it starts happening more often whenever you are on IV insulin. It's usually a drip in the ICU. These patients go to ICU initially, and so you have to titrate the insulin. You got to monitor their glucose level. How is it coming down? Once it starts reaching a 250 level, then they change the solution to NS with a little bit of glucose. So it could be like a 5 to 10% dextro with normal saline. And they do that to prevent a sort of a crash in their glucose level, like for them to get hypoglycemic um, very often, just because you're giving them IV insulin at the same time. You want to monitor their electrolytes. Initially, they're hyperkalemic because of the dehydration in their insulin glucose levels. But then as you start pushing insulin and you start giving them insulin, their potassium crashes. So you might have to replace electrolytes. Potassium in particularly is very, whether it's low or high, the heart doesn't like it. And so whether you have a low potassium or a high potassium, you can go into cardiac arrhythmias. And so therefore these patients need to be on a cardiac monitor and they need to be monitored for these arrhythmias. You might need to give some sodium bicarb if needed, and then monitor their input and output. Um, and watch out for fluid overload because you're giving them fluids, you're replacing fluid. If your patient has renal or cardiac issue, they might go into fluid overload. All right, so let's talk about the other complication, hyperosmolar hypoglycemia syndrome, HHS. Now, this problem is mainly seen on type 2, okay? Type 2 diabetics. It's considered a medical emergency. It's life-threatening. And actually, the mortality rate is, above 50%. Some of the differences is that on HHS, the clients don't have ketones. There's no acidosis state, all right? So why is it more often in type 2 diabetics is because the body is still producing insulin, but it's just not enough because of the issue that they're going through, which most of the times it causes are infections or not taking their medication or a newly diagnosed diabetic. And so then all this glucose, which usually sometimes is above 600, um, the body's going to start like diluting it and flushing it out. And so there's a diuresis process that happens, and then you lose all your fluids. You become in a severe dehydration state, and that's what's emergency about it. The cells don't like for them to be completely deprived of fluid or water. And so that's why it's so life-threatening. The onset is gradual and it's not as common as DKA, but it is very common on type 2 and the elder population, like elderly. Okay, so how do we recognize HHS, from DKA? How do we compare them? And I strongly suggest that you put them side by side. So we have severe dehydration here, dry mucosas, thirst, tachycardia, severe hypotension, You're going to have all your P's, and then you're going to have changes in LOC and your vision, but you're not going to have those ketone bodies in the acidic state, like your Kussmaul's or your abdominal pain and your nausea and vomiting. Your glucose is above 600. Um, and then the osmolarity is high. Okay, and let me talk about what osmolarity is, just as a refresher. Osmolarity is sort of the content, the solute, um, and we're gonna, I put a little cup here with water, but think about inside your plasma, your blood content. So it has a lot of molecules and a lot of concentration of solute versus solvent, the fluid. And so that's what osmolarity is. Um, and so it's almost like a water, a cup of water that you added 10 spoons of salt versus a cup of water that you just added 2 spoons of salt. The 10 spoons of salt cup is going to have a higher serum osmolarity, just so you understand what that means. So we treated immediately. These people need to go to a hospital emergency. We monitor their level of consciousness. We protect their ABCs, airway first, and then we hydrate them. We pump them with fluids. And it's just not 1 or 2 liters. We're talking about 6 to 20 liters in a less than 24 hours. So these clients are high risk of fluid overload. At the same time, we're giving them IV insulin. We're replacing their electrolyte. We're making sure that they don't get any dysrhythmias, and they're monitoring their intake and output. So the big difference here is the amount of fluids that they get. They're gonna get way more fluids than your DKA patient. All right, let's go over Simoji and Dawn phenomenon. Many students get these two confused. I'm going to try to make it as simple as I can, um, so that way you don't confuse them and you separate them. Again, this is another two sort of complications that you want to put side by side so you can see the differences. All right, so Simoji, we call it the rebound effect. So the problem here is that a client gets too much insulin at night, making the patient hypoglycemic around 2 to 4 a.m. And then these hormones that we have in our body, there are four of them: glucagon, growth hormone, cortisol, and epinephrine. Say, whoa, hold on. You are hypoglycemic. I'm gonna go and help you. So the body releases these counter-regulatory hormones, and then it raises your glucose level. So by the morning, by the time that they're taking your glucose level in the morning, you are in a hyperglycemic event. You're in a glycemic state. But the cause is you did a rebound effect. You administered too much insulin at night. That caused for you to crash, and now your body's trying to put you back into equilibrium. So the hormones elevate your glucose level, and you are now hyperglycemic. Hmm. So here, what we need to do to fix this issue is really modify your dose at night. Don't give them too much. And that's something you need to talk to your doctor and, of course, recognize it first. Um, and then suggest to the doctor to adjust that night dose. Um, a way that you can recognize it is by taking a glucose level around 2 to 4 in the morning. If they're crashing, that, yeah, when in the morning when they're hypoglycemic, that it's because they're in a Simoji phenomenon event. Now, on the contrary, we have dawn phenomenon. And honestly, dawn phenomenon occurs mostly in adolescence and young adulthood. And the reason for it is because it has to do with two hormones again, the growth hormone and the cortisol. And these growth hormones and cortisol, they're high when we are young because we're growing, because we're adolescent. They're like in their peak. They always are being released when we're young. And so the hormones get released in the morning hours between 2 and 8 o'clock in the morning, and that causes hyperglycemia in the morning. So here what we need to do is that maybe your insulin regimen may need to be increased, or the time that the insulins are administered need to be adjusted. For example, maybe giving the client a long-lasting insulin or giving them a little more at night. Just some ideas so you can understand what I mean. But here, this is just a normal part of the body. We cannot control these hormones. The young client is growing, it's in their adolescent years where these hormones are they're at their peak level. Okay. Okay, the next topic that we're going to talk about is diabetic neuropathy. This is the issue with the nerves. The nerves, the high level of glucose, they really mess up their nerves. They damage all these nerve fibers. And so it happens to, and I'm going to say this very carefully. I'm going to say it almost happens to every diabetic, honestly. Um, so very few diabetics that I know do not have some sort of neuropathy. So they lose the sensation, it causes pain, it can lead to wounds, it can lead to them not realizing that, feeling their feet and not realizing maybe they stepped on something, which leads to then wounds and amputation, burns, etc. So really to treat it, you kind of want to prevent it, honestly. You kind of want to extend the time that you develop it because usually it's most likely that it's going to be developed, but you want to extend the onset of it. So by preventing it and controlling your glucose levels, get it don't get it all out of control. So then maybe the second year that you're being diagnosed with diabetes, you have neuropathy. Um, and then another thing is that you want to protect at all times your skin and your peripheral legs. Um, so that way you don't get wounds and cuts, etc. Now, there are some medications that we can give clients, the doctors prescribe, to help with the tingling and the pain that they feel. And there are a few of them, a few classes, tricycline antidepressants, the selective serotonin, um, and norepinephrine reuptake inhibitors. And then the most commons are anti-seizure medication. The classification is anti-seizures, but they're also used for nerve pain, neuropathy, tingling. These are the ones that you're going to be seeing most in the hospital, your gabapentin and your pregabalin. Now, a couple of things to be careful and educate with clients with gabapentin or pregabalin is that it does take a little bit for them to work. Like they're not magic. You don't take them and then the next day you feel good. So it can take up to 2 to 3 weeks for them to work, as well as it can make you a little drowsy and sleepy. So you want to tell the clients, hey, be careful when you initially in the therapy, when you started um, driving or, operating heavy machineries, because you don't know how the client is going to react to the medications. they might suddenly just become very sleepy, and maybe the dose needs to be adjusted. So that's something that we need to educate them. Other complications are angiopathy, which is the damage of the blood vessels, or retinopathy can lead to the blindness of the eye, so they need to have routinely eye exams and go to the ophthalmologist very often. Then you have nephropathy, which damages the microvessels in the kidney. So they start having issues with their kidneys, elevated creatinine, and if they don't take care of themselves, can lead to renal failure and dialysis. And then careful with their cardiovascular vessels can lead to PAD, peripheral artery disease, and vascular, as well as MIs and stroke and hypertension. And we're going to talk about these in, cardiac section, but just know that again, it affects all kinds of vessels and the whole body in general. Again, my references are from the book, and all images are obtained from the book or Google. I hope this was helpful, and I'll see you in the next video. Bye.